Thank you, and thank you very much for the invitation. Congratulations to you all. You almost survived this oncology marathon. It's 9 p.m. and you're still there. Congratulations. Yeah, so Tamara is actually right. At the end of the Congress, you have to ask a friend to give a last talk, which means that I'm a good friend of Tamara's, okay? All right, so I was asked to describe for you the current situation for personalized systemic treatment for men with prostate cancer, and I will try to convince that indeed personalized medicine or precision medicine is already a reality for all the patients. My disclosures, participations to boards and talks for various companies, and the money goes to my institution, Gustave Roussy, not to myself. So, basically, if you want to speak about precision medicine, you need to understand what you are treating. It's as simple as it is. And for a long time, we've been treating patients with prostate cancer just as one disease, just because we didn't know what this was from a molecular standpoint. And I think this paper was really a first, almost 10 years ago, to explain us what's ongoing at the molecular level when patients have exhausted all the existing treatments, abiraterone, apalutamide, enzalutamide, chemo, everything. And bet what? The cancer cells mostly prefer using their favorite engine, the androgen receptor, even when you've been targeting the AR with androgen deprivation therapy, abiraterone, and enzalutamide. So in other words, instead of using another mechanism, in most of the cases, it keeps using the androgen receptor. They're able to fix the engine and make it work again and push cancer cells toward immortality, if you will. So, which means that if we are able to invent a super abiraterone or super apalutamide, darolutamide, and enzalutamide, the one you want, we may win. Having said that, in some other patients, there are other pathways. For example, an important minority of men have PTEN loss in their cancers, and actually the AKT/PI3 kinase pathway is on, which is potential target for treatment. Also, DNA repair. You hear the story today about ovarian cancer and other cancers. DNA repair is potentially also very important, and some others. But let me first focus on AR biology, androgen receptor biology. And first, the AR genomic alterations that appear when patients receive all the available treatments. Amplification is quite frequent, and actually in case of an amplification, there are more copies of the AR, so a higher likelihood that a single molecule of androgen, DHT or testosterone, can bind to the AR. And unfortunately, we don't know how to really target amplification of the AR. Splicing variants. This appeared to become famous approximately a decade ago. It's rare, fortunately, and it's actually mostly a prognostic factor. It's associated with bad disease, but it's not really predictive as we thought it was 10 years ago. So again, not necessarily a super biomarker, at least predicting for efficacy of drug. But AR mutations, which clearly appear under pressure by abiraterone, enzalutamide, and all these drugs, are quite frequent, 20–25% of the total, and they appear to be predictive for efficacy of other drugs. And I'll come back to that in a minute. But let me explain what that is. Of course, this is the wild-type AR. Androgens bind to the CTEM part of the androgen receptor. This is the normal biology. But in case of a 702 mutation, androgens will not necessarily anymore stimulate the androgen receptor, but corticosteroid can do the job. Yes, you've heard me. This is androgen receptor but it's corticosteroid binding to the AR and stimulating the AR. And now another mutation, the 878 mutation, progesterone can bind to this version and stimulate the AR biology and make the cells survive and proliferate. Which means that in case those mutations are present, and I'm speaking about 25% of patients, you can target any androgen you want with all the drugs we've been speaking about for two hours. It will not work anymore. You need to target corticosteroids or progesterones or some other ligands. And actually this is a hypothesis we've made recently when we've been developing a new drug called ODM-208, which actually prevents the making of all steroids. So it's a brutal drug. It's an artificial Addison disease treatment, if you will. You're just preventing this CYP11, which is the first enzyme just downstream the cholesterol to make mineralosteroids, corticosteroid, estrogen, progesterone, and androgens, all steroid hormones. Of course, you need to supplement your patient so that they survive, but this is something our endocrinologist colleagues know how to do. And it actually worked. In patients who had exhausted everything, you see approximately 30% of them actually benefit. And when you focus on patients with androgen receptor mutations, as we had predicted it, the response rate is much higher, about 60%, including long responses. So this was the phase 1, and we just confirmed this data recently in an expansion cohort, phase 2 cohort. All these patients had androgen receptor mutations, and it actually predicted very nicely for efficacy. As you can see, more than half of the patients derived a more than 50% decline in PSA, including some long-term responses. Actually, we had some patients, believe it or not, for more than 2 years on drug while they had exhausted everything, docetaxel, cabazitaxel, abiraterone, enzalutamide, everything. And this is associated with clinical improvement, obviously. So first example of precision medicine. You measure mutation, you give a drug, and it mostly works. Second example. As I said, approximately 25% of patients with CRPC have PTEN loss. In this patient, PI3 kinase is activated together in parallel with the androgen receptor pathway. So in this man, we should actually target both pathways at the same time. So this was tested quite beautifully in a randomized phase 2 trial, combining abiraterone with an AKT inhibitor. As you can see to the left-hand side, in patients with PTEN loss, the combination actually works much better than abiraterone alone. To the right-hand side now, in patients without PTEN loss, you don't see benefit. And what was found at 400 milligrams dosing was also seen at 200 milligram dosing. PTEN loss benefit, PTEN non-loss, no benefit. So again, a second example of precision medicine. So this is randomized phase 2. But things actually became more complex when it moved to phase 3. This is a positive phase 3 trial. By a statistical standpoint, the RPFS primary endpoint is statistically improved. P-value is less than 0.05, fine. But actually, clinically speaking, the benefit is not that big as compared to the randomized phase 2 I just showed you, unfortunately. So why is that? Number one reason, the determination of PTEN loss was by immunohistochemistry in this trial. And actually sequencing seems to be much better, but also much more expensive and much more difficult to do in a phase 3 fashion. And actually, if you redo this analysis in patients with sequencing, it's a much better difference. Second reason, and a very practical one, this combination is associated with significant toxicity. And that's not only immediate toxicity and acute toxicity, it's chronic toxicity, which of course patients hate to suffer from. You know, diarrhea every day of your life, rash every day of your life, etc., etc. And I think this is very important for us when we design trials. Before moving to phase 3, we need to make sure we have a way to circumvent chronic toxicity that we saw in phase 2. This is, you know, just a very practical reality because otherwise in this trial, they were comparing abiraterone versus abiraterone. No wonder the difference is not big. Hopefully there will be a better outcome in another trial testing the same concept, but hopefully with a safer drug and also trying to mitigate the toxicity. And this is ongoing right now. Third example of precision medicine, DNA repair, obviously. We figured out less than 10 years ago that many men with advanced prostate cancer have germline DNA repair gene mutations or other alterations, mostly BRCA2, and some others actually have the same or similar alterations in their cancers, even if that didn't come from their parents as a genetic gift. So this predicts for efficacy of PARP inhibitor, and actually olaparib was shown to improve not only radiographic progression-free survival as shown on the screen, but also overall survival. Even if many patients receive a crossover, overall survival is improved in these men with BRCA1 or mostly BRCA2 alterations. More recently, a second PARP inhibitor called rucaparib was tested earlier in the course of the disease in patients who had received only ADT and an androgen receptor pathway inhibitor, but nothing else. And the comparison for men with BRCA or ATM alteration was between rucaparib, so the PARP inhibitor, versus whatever you wanted as a doctor, between docetaxel, which is of course an important treatment in men failing an AR pathway inhibitor, or a second RP in patients not fit enough to receive chemo, not willing to receive chemo. And actually there was quite enormous crossover also in this trial. As you can see, the trial is positive. Rucaparib in men with BRCA alteration does much better as compared to the control arm. Second information, men with ATM do not benefit from PARP inhibition as compared to the control. So you need to have molecular information. Very important also, whatever the comparator, the PARP inhibitor is better in these men with BRCA alteration. Docetaxel or the second RP, rucaparib does a better job. And by the way, this is the first time in 2 decades docetaxel is being beaten in a randomized fashion. We were waiting for that for a long time. Okay, so BRCA seems to be highly predicting for PARP inhibitor in this disease. But actually things became more complex again. And very recently we saw 2 or 3 trials reading out and testing whether PARP inhibitors should be used not only in patients with BRCA alterations, but also in all comers. So let's see the data. PROPEL, testing abiraterone plus or minus olaparib. If you look at the data for men with BRCA alterations, very, very clear benefit. Hazard ratio is about 0.2 or so. No discussion. But also, and for the very first time, a more modest benefit, but a benefit was seen in patients without BRCA alterations. So in these men, it appeared that abiraterone plus olaparib was better as compared to abiraterone, with a hazard ratio of 0.76. But this is rPFS, progression-free survival, and mostly progression-free survival only. overall survival is not improved for these men without BRCA alterations. And by the way, it's clearly improved for men with BRCA alterations. And what was found in PROPEL was recently confirmed in a second phase 3 trial testing the same hypothesis with different compound, enzalutamide plus or minus another PARP inhibitor called talazoparib. And again, another issue with this combination is that they are quite toxic. You can see here a very high degree of anemia with a combination and also 7% pulmonary embolism incidence. And this is PROPEL, but the same data was found in TALAPRO-2. Again, very high degree of anemia. You need to be prepared to transfuse approximately 40% of your patients if you're using such a combination. And at the end of the day, this PFS benefit that I just reported to you did not translate into a quality of life benefit. So the question right now is really, should we really select all the patients for PARP inhibitors, or should we give them for all comers? Well, first, the PROPEL data that I showed you with olaparib are not an artifact. We now have a demonstration with a second phase 3 trial that it's a true finding. So we have to address two questions. Number one question is a scientific one. Why is that? Why do we see benefit in non-BRCA patients, even if it's not a big benefit? Is that because targeting the AR pathway together with a PARP inhibitor generates some BRCA-ness? Maybe. Or is it simply because all the tests are imperfect and we are just missing some BRCA alterations in patients that we call BRCA negative? And it could well be. For example, deletions of BRCA are quite tricky to identify by most tests. And actually, deletions predict for the highest benefit of PARP inhibitors. So it could well be. And besides the scientific question, there is a medical question now to all of us, if we can use this combination. And it's simply, is it good enough? I just showed you the data. RPFS benefit, yes. Quality of life, no. OS, no. Toxicity, yes. So we may debate and we may not have the same opinion about those things, but that's fine. Let me give you another example where precision medicine is really needed, and this is immunotherapy. Generally speaking, trials testing immunotherapy in prostate cancer have been negative. But it's really annoying, not only because it's negative, but also because in some patients, immunotherapy works. And if you look at long-term analysis of phase 3 trials, we do see a difference. Here, this is the ipilimumab trial, and you can see there are twice higher long-term survivors when they received immunotherapy. And indeed, Johan and I followed the patients who responded fantastically to immunotherapy. You know, he was very sick. He had received all existing drugs at this time 10 years ago. His PSA was 100. He was on opioids. And after ipilimumab, PSA went down to 0. Bone scan became normal. And he could stop morphine. And this was true for a long time, for years and years and years. So the key question is, we need to identify biomarkers predicting for efficacy. And we're just starting to learn. Clearly, one predictor is about MMR mutations, so MSI high, if you will, but that's only 2%, 2 to 3% of all the patients with advanced prostate cancer. So it's not predicting for all the patients I just showed you. But if ever you see one, make sure he gets a PD-1 inhibitor or CTLA-4 inhibitor, because he might indeed benefit tremendously. Another biomarker is CDK12 double mutations, so biallelic mutations, if you will. This tends to predict also for benefit, but a lower degree as compared to what I showed you with MSI high. And there are other parameters, but right now they're not ready for prime time, unfortunately. And let me give you maybe a last example about precision medicine, and this is about PSMA. PSMA is a transmembrane protein. It's very frequent in prostate cancer and very well associated with poor outcomes and aggressive disease. And the good news is that it's very moderately expressed by non-prostate cancer cells, with the exception of salivary glands. So we can image a PSMA expression using PET scan. So that's precision medicine. You can identify amongst your patients whom actually have PSMA expression, and you may select them for treatment using PSMA targeting agents such as PSMA lutein. And this is what is shown here on the slide. We now have clear demonstration from the VISION phase 3 trial that PSMA lutein can actually improve overall survival on top of progression-free survival, on top of quality of life, on top of skeletal-related events, everything basically, in men failing second-generation hormonal agents, abiraterone and enzalutamide, and chemotherapy. So this is clearly a new standard of care, as you can see here on the slide. So, and I promise I will not be too long, and I will not see the bad slide. So this is my conclusion slide about precision medicine in this disease. I think we now have clearly at least 3 examples ready for prime time, where we should actually identify a molecular analysis before we decide for a drug. BRCA alterations, mostly BRCA2 for PARP inhibitors. And if ever you cannot access to PARP inhibitors for financial reasons, you may actually use carboplatin simply, and it works, okay, for your poor patients. MSI high predicts for PD-1 inhibitors. Unfortunately, this is rare, but if you find one, make sure you get it. PSMA expressing cancers for PSMA lutein. And by the way, the higher the expression, the higher the benefit. And the list might actually become bigger in the near future. I just explained about PTEN loss and AKT inhibitors. AR mutation, I think, is a very promising biomarker for alternate ligand inhibitors and CDK12 and PD-1 inhibitors. And with this, I thank you very much for your attention. Thank you.